Good morning, and thank you all for joining us today. We are honored that such a large number of people from public health and education have taken time out of your day to attend this panel. We are going to be talking today about how a Bay Area county built consensus for school-based suicide prevention and crisis intervention. Before we get to our presentation, which we're going to go through a little bit of housekeeping with you. So please know that the presentation will be recorded, and a copy of the recording will be sent to you after the presentation along with the slides. You as attendees are in listen-only mode. Please do ask questions and interact with us using the dialog box on the right-hand side of your screen. You can submit questions or comments, and if you're a social media user, please connect with us on social media. I'm Jennifer Spiegler. I'm Senior Vice President of Strategic Partnerships here at Cognito, and we are just delighted to have this panel today. You know, September is National Suicide Prevention Month, and that designation helps us to collectively focus our attention on an important public health issue. When we talk about suicide prevention for youth, much of that focus is on schools because, after all, that's where kids are most of the time, right? So today we're going to learn about how Santa Clara County is trying to move the needle on youth suicide through a groundbreaking public-private partnership designed to bring about comprehensive suicide prevention in schools. Mego Lien is the Suicide Prevention Manager for the Santa Clara Department of Behavioral Health, and Mego has been the driving force behind this initiative, which brings together under one umbrella her own agency, the County Office of Education, school districts across the county, the nonprofit Herd Alliance, and Cognito to engage literally thousands of school administrators, educators, and school staff in the mission of saving and improving young lives. Mego, as I mentioned, is the Suicide Prevention Manager for the Santa Clara County Office of Behavioral Health Services. She will be joined in this presentation by Shashank Joshi, Associate Professor of Psychiatry and Behavioral Health Sciences, who's a child and adolescent psychiatrist at Stanford University and also a founding member of the Herd Alliance. He'll be talking about the work that the Herd Alliance is doing in the partnership. Kathy Merrick is the mental health coordinator for Santa Clara Unified Schools and a practicing mental health professional. And that's me, and I will be talking a little bit about Cognito's role in this initiative. So we have a lot to cover, and without further ado, I would like to hand it over to Mego. Mego?
Hi, Jennifer. Thank you. Can you hear me okay?
Yeah, you sound great.
Okay, great. So hello, everyone, and thank you for joining this webinar. You can advance to the next slide, please. As mentioned, the Bay Area county that we're talking about is Santa Clara County. So just to get everybody acclimated, our county is located in Silicon Valley with the city of Palo Alto to the north and city of Gilroy to the south. Our population is just around 2 million people, and we have about 35 school districts in our county. So this comes to 423 schools, and the student population is nearing 280,000. Next slide, please. So the suicide prevention program is housed within our county's Behavioral Health Services Department, and this program was started in 2010 after a cluster of suicides in the Palo Alto high schools that was actually quite high profile and covered in the media quite a bit. For that reason, our program has always had a very strong focus on youth suicide. The slide that you see here, the data here, is from a EpiAge study that was commissioned by the county and the state in 2016. The CDC came and did a study of youth suicides ages 10 through 24 in our county. And what you see here is the finding that in our county, cities of Palo Alto, followed by Morgan Hill, were found to have the highest rates of youth suicide specifically. Next slide. So this is kind of the part of our program's logic model showing the main outcome objectives that our program in the county works towards. You can see numbers 4 and 5. We definitely do a lot of work around reducing access to lethal means, especially firearms, as well as improving messaging in the media about suicide to prevent contagion and as a prevention effort. The outcome objectives 1, 2, and 3 are really what this partnership we're talking about today address. So number 1 is really around what we call suicide gatekeeping, so increasing early identification and support for people who are thinking about suicide, and involving a lot of community members in essentially the screening and gatekeeping of people who are at risk. Number 2 is increasing use of mental health services. And then 3 is strengthening community level and organizational suicide prevention and response systems. So our partnership, as I mentioned, addresses these first 3, particularly in the school setting. Next slide, please. So as Jennifer mentioned, this is a public-private partnership that we developed with the partners that are listed on the right-hand side of the slide. You can see my department, the Behavioral Health Services Department, as well as the County Office of Education are involved. Dr. Joshi is going to talk a little bit about the HERD Alliance and their involvement in the partnership. And then we selected Cognito as the training that we wanted to partner with and involve in this particular partnership. The partnership really came together in both a pretty systematic way, but also fairly organically. These are the 6 general steps that we followed to develop the partnership last school year, and we're going to talk a little bit about each of these steps. Next slide, please. So really the impetus for the needs assessment that we did initially was a California state policy called AB 2246. This was passed, I believe, in 2016 and called for all school districts and schools serving grades 7 through 12 to have a suicide prevention policy in place. And so at the county level, we really wanted to understand where districts and schools were at when it came to implementing this policy and knowledge about this policy at the ground level. So we issued this, we developed this needs assessment and sent it out across the county to all the school districts. We got a total of 25 responses representing 14 different school districts, so about half, just under half of the school districts in our county. And approximately 56,000 students were represented by these 14 school districts. Because the policy covered grades 7 through 12, we weren't surprised that most of our responses, sorry about that, most of our responses came from high schools as well as middle schools. And our survey respondents were a diverse group of people, principals, student services coordinators, different administrators at the districts. Next slide, please. So one of the questions we asked was, does your school currently have a suicide prevention and intervention policy in place? So just general, is AB 2246 being implemented at the school level? And because of this policy, the majority of districts all said yes. There either was a policy in place or they were in the process of updating or developing it. So that was good to see. Next slide. We then asked about more specific knowledge about different protocols for suicide prevention. And on this slide from left to right, these are protocols generally going from lower risk to moderate risk, and then suicide attempts, followed by re-entry and postvention response to suicide deaths. So you can kind of see here that when we ask more specifically about knowledge about protocols, generally knowledge decreased as we got higher risk in terms of the protocols. So a majority of folks said that they did know about the protocols for supporting low risk or moderate risk students. There were about half that did not know about protocols for suicide attempts, either in school or off campus, out of school. And then about half also were not familiar with re-entry protocols or response, and then much fewer people knew about response to actual suicide deaths in their school communities. Next slide, please. We also asked generally about promotion as well, and we saw here that there seems to be a lack of trainings. Beyond trainings in suicide prevention for mental health staff, a majority of teachers, other school staff, and students as well had not received any suicide prevention trainings in the past school year. So this was an area of need that we really identified through the assessment. Next slide, please. We also asked for survey respondents to tell us their top 3 issues when it came to suicide prevention. And so in line with the other findings that I just showed you, under promotion, there was the strongest interest around trainings for a variety of audiences within the school community, and having those trainings be systemic and sustained, as well as promoting SEL, social emotional learning, and comprehensive wellness. Then there was a lot of interest around intervention and response, crisis response protocols, as well as those re-entry and safety plans and aftercare. And then followed by interest in general mental health services for students as well. Next slide. So from there, we went about developing the partnership, really looking to respond to what was identified in the needs assessment. And you could go to the next slide for this, please. Our 2 main goals for the partnership was really, one, to kind of help to fill that gap with the suicide prevention trainings, especially with the gatekeeper trainings. We know through a lot of evidence about the potential benefits of gatekeeper trainings that you can see here on this slide. Increasing support available to students, definitely increasing identification and support for students who are at risk, and then generally helping to reduce stigma around mental health and suicide and improving the school climate. So that was really one of our main goals for the partnership. If you could go back, please. The second goal for the partnership was really developing crisis response protocols and responding to that intervention need that was identified by the survey respondents. And then lastly, we really looked at trainings and crisis response protocols as entry points to more comprehensive suicide prevention. So in the long term, we really wanted to expand from trainings and protocols and look at even more systemic change, like social emotional learning, for example. Next slide, please. So we had a number of assets and available resources to us, and really developing the partnership was looking at what we had available and trying to pull it all together for maximum impact, really. In terms of policy, our program is funded by a state tax called the Mental Health Services Act. And then we also had, as I mentioned, this policy AB 2246 that really increased the priority on suicide prevention for school districts. We had really great leadership that had buy-in to suicide prevention, not only in my department, but also at the County Office of Education, and a lot of very committed community members and organizations to the youth suicide prevention effort, such as the HERD Alliance. Jennifer will talk a little bit more about why we particularly selected Cognito as a training for this, the training partner for this partnership. And then in the first year, we had 7 school districts participate. So we called them cohort 1. And then for funding, lastly, we had a combination of funding available through the Mental Health Services Act, and we developed a cost share with the districts, as well as getting a group discount from Cognito. Next slide, please. So this is the basically what we went to school districts and pitched to them. We had some criteria for participation in the partnership. One of the first criteria was to have an AB 2246 plan policy written up and in place. We also needed school districts to identify implementation leads for all of this work, both at the district level and at each school site level, which was particularly important for rolling out the Cognito training and really being a champion on the ground for the training. School districts that participated committed to training all of their teachers and staff in the first year using the Cognito at-risk modules. And they did this and accessed the license through a cost share with my program at the county. They then also agreed to participating in consultation with the Herd Alliance team on crisis response protocols and basically updating or developing their protocols to be in line with best practices that were recommended by the Herd Alliance. And then we kicked off the entire thing and developed a community of practice, I think right before the school year started in August or September. Next slide, please. So you could go to the next slide. We had this community of practice. These are the 7 school districts that participated in the first school year of this partnership. It really was a diverse group of school districts and geographically located across our county as well. And we found immediately a lot of benefits to having this community of practice in place, especially not only through cost sharing to be able to afford the license for the Cognito training, but also in leveraging one another's strengths and resources and then sharing our experiences through the partnership. We were all really learning as we went along, so it was great to be able to have that dialogue going on throughout the year. Next slide, please. So this was the general timeline of putting the partnership in place. It really took a number of months at the beginning of the school year to both develop the partnership and to get school districts on board. That was a lot of legwork and a large piece of the development process. As I mentioned, we had a kickoff meeting in August 2018 with all of our partners, and that was an opportunity for all of the partners to come together, get some introductions going, and have the districts develop some draft rollout plans for how they were going to roll out the Cognito training throughout the year, and then when they would be working on their crisis response protocols with the Herd Alliance team. The districts then had a number of months to plan and roll out their plans according to whatever they needed and their own district needs. So that was not really prescribed. We left it to school districts to determine, what professional development days they would be rolling out the training, when they would be working on their crisis response protocols. And each district had different needs, obviously. So that was important to give them some flexibility there. And then by March and this past summer, all of the districts had rolled out the training and done some initial work on their crisis response protocols. So we spent a few months doing the evaluation and then gearing up again for year 2, which is just now starting up. So that's the overview of the community of practice, and then I'll hand it over, I think, to Jennifer now to talk about the Cognito training more in depth.
Thank you so much, Mego. I feel like when you're talking about this project, there's like a modesty in the way you talk about it, but I have to say it's so methodical and thoughtful and robust that I just want to point that out to people on the phone, and it's been such a pleasure. For those of you on the line who don't know Cognito, we're a health simulation company that believes in the power of conversation to improve all kinds of health outcomes, including mental health. We've been working with public health and education agencies for over a decade to provide schools with high-impact, evidence-based online professional development and curriculum resources that include our signature interactive role-play scenarios. And I'm going to show you what that looks like real quick. As I look at this slide, I see that it's out of date a little bit because I know that since April we've trained over 100,000 school personnel in the state of Florida. One of the real benefits of our program is scale. And so we've had the pleasure of working with a lot of school districts and state level school education and public health agencies over these past 10 years. Our platform has also attracted a number of partners at the local, national, and international levels, and you can see some logos there on the right-hand side of your screen. But let's jump right in to looking at what is a health simulation. In this case, the Cognito Learning Platform has been really recognized as a best-in-class educational tool for schools, as opposed to being a standard sit and get or kind of online training that you can press play and then walk away and do your dishes. This is a really highly interactive platform that is evidence-based and scalable, provides hands-on learning and immediate feedback to the user. It has been designed specifically for school personnel with input from hundreds and hundreds of educators, and it is tailored by grade level to make it even more relevant, so the learning really sticks. But let's take a look at a live version of the simulation real quick. I will just give you a sense of how it works. Okay, so you're, in this case, you're a middle school teacher. You are taking on the role of Mr. Bauer. You see him there seated on the left. And he is talking to a student, Michael, who he's very concerned about. Why is he concerned about Michael? Michael has written a journal entry about his uncle who is terminally ill and dying, and Michael has expressed his desire to be in his uncle's place and be the one who dies because his uncle is such an awesome guy. And so this is one of 3 scenarios in the middle school training. There's also a separate training for elementary schools and a separate training for high schools. Each one of them has multiple conversations so that you as a learner can be exposed to different challenges and learn and build your skills in that. So in this scenario, you're taking on the role of Mr. Bauer here, and the way you navigate this conversation is to use this dialogue to choose what you want to say, how you want to address this conversation with Michael. So you can make small talk, you can jump into discussing your concern with his journal, or you can refer him right away. And let's just say, let's discuss the journal.
You wrote some pretty unusual things in your journal today.
I know, that was dumb of me. I guess I messed up on that assignment.
Okay, and now you have some feedback from your virtual coach who says rather than negatively labeling Michael's writing as unusual, which could upset him, keep your comments neutral. And you can see Michael is an emotionally responsive virtual human. He has memory and emotion and a personality, and he's going to respond like a real person would. In this case, you used a term that is a little inflammatory, and that wasn't your best choice. You can see here, you could also undo that decision and try something that maybe would be a better decision along the lines of your coach's feedback. And we can choose a different way of discussing
your journal today, and it seems like you have some pretty serious things on your mind. Sounds like your uncle's been pretty sick with cancer, and that's been hard for you to handle.
Oh man, yeah, that's been rough.
Okay, and then you see a very different reaction from Michael. And you can notice that down here on your screen, you have the student comfort meter, and his comfort has increased because you used a targeted tactic. So we have embedded in these simulations a number of communications best practices based on motivational interviewing, as well as other theories and techniques, and you will be exposed to these over and over again as part of the attempt to have you adopt these strategies as your own. I think in the interest of time, we're going to flip back to the slides, if we can. Next one, please. So how do we know that these are actually impactful? In fact, field studies with hundreds of thousands of users demonstrate the effectiveness and sustained improvement in skills, attitudes, and behaviors using a validated scale called the Gatekeeper Behavior Scale. And we've been able to demonstrate increases in the number of students who are identified as needing support, who are talked with and referred for mental health support services, as you can see here. And a growing number of peer-reviewed journal articles have been published looking at efficacy, including in the Journal of School Health, the Journal of Suicide and Life-Threatening Behaviors, the Journal of Technology and Behavioral Science, which is an article that's currently in press. I think what's important to mention, too, is that the majority of educators completing simulations also believe that they'll have some upstream benefits. And Mego had talked about her goals in affecting some of those upstream measures, such as reducing stigma, improving climate, and looking at some more systemic change. In this case, educators have told us that they believe the simulation will have a beneficial effect on helping them build better relationships with students, improving student attendance, improving their academic success, and improving school safety and creating a safer and more supportive learning environment. I would say that the trainings have kind of been a catalyst in this process, and I think the next person to speak is Dr. Joshi. So take it away, Shashank.
Good morning, everyone.
Shashank, I think you might be muted. There you go.
Great. Thank you so much, Jennifer. And thank you, Mego and Maria for getting us started, and Scott for troubleshooting. I'm Shashank Joshi, and I'm an associate professor at Stanford. I've been involved in school mental health for all of my 20-year career at Stanford, as well as my career before that at Albert Einstein College of Medicine. And I'm going to take you through a very interesting project that I guess you would say came about as we were facing our grief, dealing with our grief and wanting to turn it into positive action. And so my colleagues, Mario Jackian, Linda Lenoir, and a number of others around our community in Palo Alto, as well as in Santa Clara County, came up with this idea of bringing together the best practices that were out there. This was the ask of several of our local school districts. And so we came up with a toolkit, which is known as the K-12 Toolkit for Mental Health Promotion and Suicide Prevention. And there is the example of something from our webpage. You can see scrolling across the top there. If it were online, you'd see some crisis numbers as well. There is the website for you to access this open source free online tool. And there's also a PDF version, which is a bit longer. It's about 300 pages. If you go to the next slide, the idea behind this is that we compiled what the best practices were into 3 interrelated sections. The first section, it covers the promotion of mental health and well-being. The second is an intervention in a suicidal crisis, which is often where school districts find this toolkit. They are in crisis and they will do a search for school crisis intervention tools or toolkit. If you're ever looking for our tool, and I think you'll have access to these slides, the idea here is it should be very easy. So if you just do a search for K-12 Toolkit HEARD, H-E-A-R-D, you see the logo up there in the northeast corner. And as you can see, it's green, which is the color of life, color of suicide prevention. It's in the shape of a heart, and there's an ear. Like I heard you, this was actually designed by a local high school student. HEARD is an acronym for Healthcare Alliance in Response to Adolescent Depression, which is loosely representative of HEARD. And we're an alliance because we include not only mental health care stakeholders, but also school stakeholders and primary care stakeholders. So it's a collaboration among those three, not only locally, but also nationally, because we've been involved with a number of other groups in putting together and then updating our K-12 toolkit. The final section of the toolkit focuses on postvention. Postvention refers to all of the different responses that occur after a tragedy, in particular for us in the K-12 toolkit, after a suicide of a community member, be it a student, be it a teacher, or someone else that might affect our school community. If you go to the next slide, the first section, which focuses on promotion of mental health and well-being, was expanded significantly. So in the first version, which came out in, was developed between 2011 and 2013, the first version came online 2013. Most of it focused on crisis and postvention, because that is what we dealt with in Santa Clara County for the most part. That's why we were called in to provide technical assistance and help schools through the process, from when the news is first learned, to when it's announced to the community, to how it's handled in the press, to how the school district and how teachers and wellness coordinators and other people get interviews for the media for how to engage not only with them, but also to get a message out that is on point around linking suicide postvention to prevention, and to supporting people on the ground, not only in the first few days and weeks after a death, but also in the several weeks to months after. And so in the first section, you can see on this slide, there's training and education there in the left corner, with a number of tools where we highlight what is out there, what does the evidence show to be efficacious for educational programs, for youth mental health awareness, for gatekeeper training. There's a expanded section on healthy adolescent sleep, as well as on self-care for educators. The next section talks about positive school climate, a specific section on preparation of protocols, then identification of mental health resources. We use the example in our community, but there are a number of fillable forms on this open source document that we want people to download and make their own. And finally, some protocols for how to identify at-risk students. So all of these are placed in the toolkit for informational purposes. If you're in California, you can use them directly. If you're outside of California, the idea is most of these that we have taken from our best practices that are out there, either from SAMHSA, National Center on School Mental Health, other organizations, and then we've adapted them for our community with permission, if they're copyrighted or open source. But we want people on this webinar to be able to utilize the tools that we're highlighting and make them your own. And that's why we're illustrating this sort of consensus process and what we did as a Herd Alliance, not only with the toolkit, but also in offering technical assistance to the districts that have adopted the Cognito platform. Going to the next slide. We just want to highlight a few of the things. So within the components of promotion of mental health and well-being, three of the major areas we focus on are things like school connectedness, social emotional learning, and mindfulness. There's a lot of research being done now through groups like Mindful Schools and other organizations that are showing some of the best practices in how to teach using mindfulness and how to teach mindfulness in the classroom. In the next slide, we also, in that section on promotion of mental health, you saw a number of the other components. Again, here, section 2, this is often where folks will find our particular toolkit. They're in crisis. So on the web version of our toolkit, which is briefer than the PDF, the web version really focuses on those tools and those websites and those forms, which are going to be most useful if you access them through the web. So in our example, what is a crisis response team? How do you form one? What are the roles and responsibilities? What's a template for how you can form your own crisis response team? What are some examples of crisis intervention flowcharts and checklists that you'll want to have for your administrators? When you do a training on your version of the toolkit, you'll want the administrators to have seen these tools before there is a crisis. What does safety planning look like? Safety planning is not the same as a no-harm contract. A safety plan is a best practice intervention for planning when you have a student that has had serious consideration of suicide. We have an example of that I'll show you in a few slides. What is the reentry plan like for students who have had to leave school, either because they've been hospitalized or they're in some other type of program? They went to the emergency room because they were in a suicidal crisis and they eventually come back to school. And then finally, what are the forms to use so you can document the different steps that you have taken as school personnel to ensure the student's safety and reentry into school and access to the curriculum. On the next slide, so we are continuing now in the crisis response section. It breaks it down a little further. What is the purpose of a crisis response team? Who is part of this team? And what are the duties of the team? And the next slide, still now in section 2, the crisis intervention. Here are some examples of fillable forms that any of you can use and start populating this afternoon or this weekend if you want to play around with them. A couple of examples here to highlight. Not only crisis response team info, there's a suicide risk assessment. This is an adapted version that we have developed for our schools here. Of course, we use the Columbia as well, as most of you probably do. One of the things we found is for elementary schools in particular, there is a form called the concern form, because most elementary students don't come in suicidal crisis. They're in some sort of behavioral or emotional health crisis that a teacher or a staff member might want to help with. And so this form was developed with stakeholder input from elementary school teachers, principals, and counselors, so that a 3-page form can really help an elementary staff member identify what the important aspects of that student's concerns are. Example of flowcharts, in our community at the time in 2009-10, the schools really wanted a protocol and a flowchart. Okay, if a student is low risk, what does that mean? If they're moderate risk, high or extreme risk. Of course, many of you know in the field of suicidology, we haven't really come to consensus about what is meant by moderate risk versus high risk. For example, some in the field would consider any teenager who has attempted suicide previously, or say within the past year, they're going to be at moderate risk for the remainder of that academic year. Others feel that once you're out of the suicidal crisis and in treatment, you can actually go down to low risk. And so I think these are cultural norms and they're vernacular norms that you would have to work out within your school district. Our districts in Santa Clara County have found those forms helpful. Again, these are examples of templates and forms that we have designed, but we want people to utilize them, adapt them for their local communities. If you go down further on that slide, you see some documentation forms, some forms for parents, for example, that last bullet there, when your child expresses suicidal thoughts, and again, a link for the website where you can access these tools. If we go to the next slide, I'm aware of the time here. I'm going to take about 5 more minutes and then turn it back to Jennifer and Mego. Highlighting here again, the safety plan. This is not the same as a no harm contract. A safety plan is a best practice tool that is used in order to help a young person, really anyone who's struggled with suicidal thinking, but since we're talking about schools, it's to help them identify a list of coping strategies, distraction techniques, sources of support, and strategies they can use before, during, and after a crisis. This plan is very brief. It's in their own words. It's very easy to use. If you were looking for this form, the 2 best ways to find it are, number 1, online. If you simply do a search for safety plan template, Stanley and Brown, or Brown and Stanley. That's the first hit that will come up. It's a one-page document which has been adapted into an app. You can go and download this app or go online at my3app.org. My3 was developed in California. My3 basically refers to my 3 people that I rely on when I'm in a crisis. If you open the app, the first thing that you see are their 3 faces in the form of a radio button. You press the face, their phone number comes up, press the phone number, it calls them right away. So who are the 3 people you really rely on to get you through a crisis or when you're having a hard time before a crisis? So hence the name My3, and it's an app, so My3 app. And so we highlight this in the Herd Alliance Toolkit because kids, of course, live in the digital world, as do many young adults. And so we want to make sure that they have access to their safety plan without having to find that piece of paper. If they're in the emergency room and they don't have their phone with them, or they don't have access to the plan, they could take a picture of it. The picture can live on their phone, but having the app is really the ideal way to do it. This app has now been taken over by the National Suicide Prevention Lifeline, and again, is a national best practice that we've highlighted here. On the next slide, we've moved now from the crisis intervention section to postvention. Postvention, as my partner, Mario Jackian, and Linda Lemoire like to say, postvention is prevention. They're all of the things that one does after a suicide, all of the interventions. And the reason we talk about postvention with prevention is because in the midst of our grief, as we try to support those who've been affected, we also want to make sure that we don't increase the risk for further deaths. And so we want to support all members of the school community, and we want to think about some basic principles. For example, responding to a loss by suicide as we might respond to a loss by another sudden tragic event like a car accident or a heart attack. This actually helps us prevent contagion or cluster. Teens are very high risk for copycat behaviors. The media has a very important role to play as part of the solution, because unfortunately, if they're not part of the solution, they're often part of the problem. This was highlighted in the CDC EpiAid report that was done here that Mego highlighted at the beginning of the webinar. One of the things they found is looking at almost 300 radio, news, and TV pieces that were covered between 2003 and 2015 on average. For every one of the articles, they got 4 things wrong and 1 thing right. That had to do with the complete either lack of knowledge or actively ignoring the guidelines that have been developed by the media for the media, which can be found on many national websites, including the AFSP, or if you do a search for reporting on suicide, they have a website, reportingonsuicide.org, where they go over the national best practice. These were developed by the media for the media, a very important part of postvention. And so we highlight those sections in our toolkit. And then most importantly, we want to identify, monitor, and support those vulnerable students, not only those who were very close and connected to the teen who may have died, but also people who have had a history of suicide, suicidal behaviors or suicide ideation in the past, because they can be actively triggered by a death of a community member. On the next slide, in postvention, what we are trying to do is really give administrators a concise step-by-step guide with examples of, okay, here's the first letter that would go out to the community if you hear about a death, even before we know it's a suicide, or if it's been not confirmed a suicide yet, or if we know it's a suicide but the family members don't want it talked about yet. There are many specific templates of letters. Principals have found these very helpful for those who are going through this for the first time. We have examples of recommendations for memorials. Often memorials will crop up on the first or second day after someone dies. What do you do about those? What do you do about the year anniversaries? What do you do about graduations? What do you do about the yearbook? Many of these concepts are covered in other national best practice manuals, such as the After a Suicide Toolkit from AFSP and SAMHSA, University of Maine, University of Florida. There are several. We have taken all of those and put them in one place. We've also been updating our toolkit. So right now we're in the 2019 update. There are a number of new ones, for example, related to things like 13 Reasons Why. Some of you know that there is a 13 Reasons Why toolkit.org website with a number of best practices for how to talk to your teen, how to talk to your student, how to talk to your patient if you're a doctor about this particular series. What are some ways to have good conversations about mental health related to the series that has certainly been criticized for very important reasons, but also may present an opportunity for discussion of important topics related not only to suicide, but also promotion of mental health, well-being, and help seeking. If we go to the next slide, wrapping up here, the last part of this goes into long-term steps after a suicide, very specifically around what schools can do with regard to the crisis response team, how you stay updated with keeping your staff and your community updated, providing ongoing community education, and in particular, really helping administrators understand that suicide prevention and well-being promotion go hand in hand. There's often a great sense of urgency after someone dies, but then a month or two after, they've kind of moved on to business as usual. And that is a place where those of you on this webinar can really have an important role to remind administrators that postvention is prevention. If you've had a death in the community that brought stakeholders together, make sure you bring them together again 3, 4, 6 months after and at the end of the school year so that you can take important elements of this toolkit and adapt them and be ready the next time there is a tragedy. So with that, I believe my section is done, and I'm going to turn it over to Jennifer and to Kathy Merrick. I think you can move on to, there you go.
Thank you. And thanks. Kathy, go ahead.
Okay. Hi there, I'm Kathy Merrick, and I work for Santa Clara Unified School District. We actually met Shashank and the Hurt Alliance about 10 years ago when we had the loss of a student, and they were incredibly helpful. I had just entered this role as mental health coordinator. I was previously a high school teacher, and then went back to graduate school and got licensed, and so I have a lot of empathy for the role of the teacher as well as respect. So entering this partnership has been really key for us at Santa Clara. We are a large district of 28 schools. We have 18 elementary schools as well as, we have 42 programs total, but 18 elementary schools, 4 middle schools, 2 comprehensive high schools, and then 3 alternative high schools. So we can go to the next slide. I'm just going to walk you through how we implemented this program, Cognito. I will say I just looked at my numbers this morning. We've trained 1,200 people in my school district in one academic year, which was pretty incredible. So I'll show you how we did that. First of all, we wanted to get the largest number of people trained. We met with the directors of curriculum and instruction. We went to the cabinet and we asked them to actually take the simulation so that we had buy-in from the absolute top. We explained AB 2246 and explained how Cognito would help us remain in compliance. We already had our board policies, et cetera, in place, but we did not have several of the key elements. One of those elements was a global sort of district-wide process and protocol for threat assessment. So what we did was we gathered a multidisciplinary team to look at what best practice we wanted to adopt. We gathered the lead school psychologist, the lead nurse, 2 administrators, the lead counselor, and the person who oversees our clinical associates, as well as myself. And we adopted the Hurt Alliance toolkit, which was really easy to adopt because they make everything so accessible. And we could actually really just all agree, because when we sat down together, we realized school psychs were using different forms and different protocols than the nurses. And from our clinical staff, we have 24 licensed clinicians who are on our sites. At the secondary level, they are full-time licensed clinicians on each site. They're called our wellness coordinators. And so they had different practices than our administrators, et cetera. So we met with the Herd Alliance, and they helped us adopt those forms and answered questions for us. And then we actually took those to each secondary site and met as a crisis response team per site so that everybody was in the same room. Any person who was going to be performing or coming in touch with kids to do a risk assessment, we all met in the same room to talk about how that was going to roll out at that site. And that was hugely helpful, and I'm glad that we did that ahead of time. We were doing that in anticipation of this training actually really, resulting in more kids coming to us for threat assessment or risk assessment. So we can go to the next slide. So we launched Cognito in January. I will say the hardest thing about launching Cognito was actually finding the professional development time because, as you know, in educational settings, professional development time is highly sought after. We have a lot of competing interests with curriculum adoptions, et cetera. So we had to take it to the secondary principals and explain AB 2246 and their responsibility in having their staffs trained. And so once we did that, they found us space. So we were able to launch in January on one single day at all of our secondary sites. With the wellness coordinators taking the lead, we did it with about a 30-minute lead-in of our county level statistics and the rationale for teachers to understand the why. And then we got them on. Different sites did it in different ways. Some all stayed in the same room with earbuds, and some sent people off to their classrooms to complete the training. But we had over 500 teachers and administrators trained that day. It was very easy. We did not have many technical difficulties other than overloading a router and people needing to disperse. So that was actually surprising. And then we also knew we wanted to identify at each of our sites people who were really key players in the lives of students and often have one-on-one relationships. And so paraprofessionals are one-to-one aides or classroom aides, are people who are often in contact with kids and they have the relationship, but they don't have the training. So we wanted paraprofessionals, security guards, our front office staff to be trained as well. And so we actually had a day of training in March for those people. Again, another in one day, over 450 people were trained in one day, and that was about a 30-minute lead-in again. We really tailored it to the role of the more individual interactor in terms of the lead-in and how much they needed to know, but they then went off and completed the Cognito training. We did provide a follow-up, a debrief for teachers and staff afterward to kind of hear what happened for them, what they thought of the program, questions they had about referrals, and we did that during a staff meeting at each of our sites about a month out. During that time of training, our elementary sites got wind of this, and so many of them wanted to participate as well. And so we had sort of individually driven professional development happening at our elementaries as well. And so we've trained 12 of our 18 elementary schools as well. Also, that was led by the wellness coordinator on those sites. So directly after the training, teachers reported that they learned skills that they could actually implement the next day, which if you know teachers, often they're quite frustrated by the professional development that they get if they don't feel like it's actually pertainable to what they do day to day. At one of our high schools, we actually had 4 referrals the next day, and 2 of those 4 students ended up hospitalized. So we were really happy that we had our crisis response teams working together and sort of articulated how that process was going to roll. And so I think overall teachers and admin, as well as paraprofessionals, were saying that they felt like these were usable tools. They were helping them connect with kids, regardless of whether or not those kids were in distress. They were just good interpersonal tools. So I will say unintended outcomes, I should say, is that the nurses took this and revised their protocols around looking at and asking more questions around sleep. The crisis response team trainings have resulted in us actually doing a deeper dive in all of our crisis response team trainings, as well as teacher trainings around crisis response. And it's also opened up an opportunity for us to get directly to students, because now we have teachers and administrators really wanting to invite us in to do more of the direct student contact with curriculum, social emotional learning. And so that's kind of our direction this year, is really getting directly to students as well as supporting teachers. So that's how we implemented it, and it's been incredibly impactful for us as a school district. And actually the teaming with MEGO at the county as well as the Herd Alliance and Jennifer has been such a good thought network for us. And so it feels like we're well supported in moving that forward. All right, thank you.
Okay,
Great. Thank you so much, Kathy. I'm going to hand it over to Mego.
Yes, so we only have a couple minutes left. I just wanted to share some early evaluation data, and hopefully I'll go through this really quickly, and then hopefully these slides will be shared out so you can take a look in more detail at some of the early data that we have from year one of the partnership. Next slide, please. We ask some of these measures across all of the gatekeeper trainings that we give, not only Cognito, but you know, the QPRs and assists, et cetera, at our program. And so basically what this slide is showing, these are measures on knowledge, awareness, and self-efficacy, specifically around suicide gatekeeping. And we saw statistically significant increases in the average reported ratings on each of these measures from pre to post. And through the Cognito system, we also have access to follow-up, 90-day follow-up data as well, which we're currently looking at. But basically, you can see in the post-training, this was a Likert scale 1 through 5 on strength of agreement. And so post-training, we had mean scores much closer to that 4 or a little bit above in agreement on each of these measures. Next slide, please. In terms of behaviors, this was asking about agreement from middle school and high school educators on was there an increase in the number of students that you engaged with regarding their psychological distress after the simulation, after taking the training. And so basically there were increases reported in students that were recognized for their warning signs, approached to discuss concern, referred to support services, and then also an increase in conversations that trainees had with other teachers and staff about students they were concerned about. Next slide. We also surveyed the district leads specifically about the work on the Herd Alliance, with the Herd Alliance toolkit on the crisis response protocols. And a good number of them, these numbers are districts. So 4 out of 6 districts, for example, started crisis response teams for each school. There was good progress that was made last year, and these districts are continuing on this year. One of our learnings was that this work could take multiple years to really develop the crisis response protocols and implement them well throughout a district. Next slide. There was also some qualitative data. I think what Kathy shared was really the best endorsement of the work, both with Cognito and the Herd Alliance. But you can see here, we have caught kids earlier and have been able to intervene at crucial times, teachers feeling more empowered, and the protocol from the Herd Alliance giving a good template to initiate conversations. Next slide. So as next steps, cohort one of the great benefits of Cognito is that they have other modules. And so the districts that participated last year are now moving more upstream in their training content. Most of them are doing the module on trauma-informed practice this year, or a few of them are moving into parent or student education using the friend-to-friend Cognito module, which is the peer simulated conversation. And then again, they're doing ongoing crisis response protocol work. We have 6 additional districts that have joined on this year, and so they'll be starting with the at-risk Cognito module. And we've also had interest now from schools outside of the public school system, like after-school programs and the Catholic schools in joining the partnership as well. So I'll just leave it there and then give it back to Jennifer to close out.
Great. Thank you so much, Mego, Shashank, Kathy. This is such great information that you're sharing and such an inspiration for those folks on the line who are either on the public health side, on the clinical side, or on the education side. It looks to me like you have, in the course of the presentation, answered all of the questions that have been coming in that anticipated answers that were covered. And one question that just came in, thank you, Linda Lenoir. How can a district get started on intervention protocols and forms if not in Santa Clara County? I think that can go to you, Shashank. You mentioned that, but please just recap how folks can get connected to the protocols.
Yeah, sure. So again, if you go to the website, herdalliance.org, you will see on the website, actually, the first thing you'll see is a tab called What's New, and you click on that and you'll see the toolkit. Those forms are there. You can go right into the forms. There are a number of appendices with the forms. If you look at the PDF and download that, if you download it onto your computer, and if you open it in the Adobe Reader, you'll be able to see the fillable forms, and you'll be able to search by the particular area that you might be interested in. One note there, again, as I mentioned before, several sections have been updated and several new sections are being added, including ones that focus on cultural elements of suicide prevention. We have new sections on working with kids in special ed, working with kids who are affected by addiction, working with faith-based communities, working with we already have a pretty robust section on LGBTQ communities, but that section is being updated as well. So over the course of the next 4 to 6 weeks, you'll see newer sections that have been enhanced. But as it is right now, it's listed on the SAMHSA, one of the SAMHSA tools, as well as on the California Department of Ed, as a tool that people should be using as an open source to be able to implement best practice in their community. And so if you want to get started, simply go to the toolkit and start searching, because you'll see some pretty easy to follow guides there for your own community.
It's truly an amazing resource, I have to say, and I know that we have folks on the line from all over the country, so I encourage you to take advantage of that. And in closing, I just want to remind everyone that you will be receiving these slides and recording of the presentation sometime later today or tomorrow, and we will include in that send a case study that was drafted by Mego Lien and Colleen Riley that sort of recaps a lot of this partnership and process. And I imagine we will be doing a follow-up webinar to talk about how year 2 of the partnership has gone at this time next year. So great thanks to the audience and to all of our presenters. And off you go for the rest of your day. Thanks, everybody.
Thanks, everybody.